Walking into a hospital and seeing something like a man cave generate feelings in a gay man seeking care around their prostate cancer. We're talking about homophobia, how the institution relates to you and how the institution welcomes you warmly and snugly and holds you with the care that you deserve, or somehow challenges your feelings around that. I'm speaking with Dr. Callen Baker, who's a brilliant and nationally known public policy expert. He studied and got his PhD from Johns Hopkins University. Speaking to a policy expert is rare and golden, and we're very privileged to have Dr. Baker here today. Welcome.
Thank you so much for having me, Darryl.
Dr. Baker is the executive director of the Whitman Walker Institute, which is the policy and health policy research arm, education arm of the Whitman Walker. Actually, what do you call Whitman Walker?
Whitman Walker Health. So Whitman Walker Health is a federally qualified health center that is just about 50 years old here in Washington, D.C., and it historically has focused on LGBTQ plus populations and people living with HIV. And so the Institute, as you noted, is the research policy and education arm of Whitman Walker.
So tell us what your concept of trust is for a patient seeking care in a hospital.
When I think about trust, it's really about that feeling of being welcomed, of feeling like this is a place that's for you, that is going to welcome you in. It's going to walk you through all the steps that you need to get care. It's going to make sure that you feel good, that you feel affirmed and respected as you're getting care and going through all of the other things that go along with cancer screening, cancer treatment. And another thing that I think about when I think about trust is how prevalent mistrust is for so many of our communities, for LGBTQ folks, for communities of color, for people with disabilities, or folks whose primary language isn't English, just as a couple of examples. The medical and scientific institutions in our lives have too often not treated people very well. And so there's a very deep current for a lot of folks of mistrust around, do I believe that this is really a place that's going to take good care of me? And too often we think about mistrust as something that simply needs to be gotten over. It's like a disease, like, oh, we should just go cure those people or those communities of mistrust so that they can just get the care they need, because that's why we're here. But mistrust is a very rational response to historical and ongoing mistreatment. So it's not about encouraging people to get over their mistrust or distrust of an academic institution around research, for example, or a medical institution around getting care. It's about making those institutions trustworthy.
Right. I mean, it's not the patient's job to change a hospital or to change their perception of a hospital. What are the things that hospitals, what are the pieces of a hospital experience that might signify to a patient, this is a place that either I trust or don't trust?
There's multiple levels. If you think about even just approaching a building from the outside, maybe as a person with a disability, thinking about, is this building literally accessible to me? Can I get in the front door? Is the doorway that's accessible to me as nicely laid out as the door for folks who are walking up, for instance? And then getting in there and seeing the people behind the desk, seeing whether they are people who, for example, share the same race with you, the same ethnicity, are people who you look at and you think they can understand, maybe at a more personal or readily accessible level, what it's like to be me, to be, for example, a person of color or a transgender person or a person with a disability walking into a situation that's already scary enough, getting healthcare, and particularly around cancer. There's so much that people are already worried about, that coming into a space and really seeing friendly faces, seeing faces you can recognize and that you can believe will empathize with you, those are some important first line indicators that I would look for. For LGBT populations or patients, thinking about the historical and ongoing degree of homophobia and transphobia that pervades so many of our medical institutions. Some simple things like a rainbow sticker, a rainbow flag. I was talking with my mother over the last year or so. She was moving into a retirement community, and we did a lot of tours of these different facilities, a little bit different than cancer treatment, thank goodness, but still looking at an institution and thinking, how is this going to go? And we visited a number of them, and the one that stood out to me, and actually the one that she ended up choosing, was one that had a rainbow flag in the sort of welcoming area. And it literally made that space, to me as a queer and trans person, welcoming. Just seeing that, knowing that somebody had thought enough about it, made a really big difference to me. So those little indicators, rainbow pins. My partner is a provider and wears a little rainbow pin, around the hospital lanyard. So those are some, quick indicators that you can pick up anywhere you go, rainbow flags, stickers, pins, little things, but that can mean a lot for people who are coming in seeking services. And then the last couple of things that I'll mention are thinking about pamphlets, educational material. What kind of issues do you think your patients are facing? Do you recognize, for example, that there are transgender people who might be dealing with different types of cancer? A transgender woman, for example, who's dealing with prostate cancer, a transgender man who's dealing with cervical cancer. Do you recognize that there might be folks like that in your waiting area who need to have the information in order to make sure that they're getting the right screening or getting the right treatment? So the educational materials that are available in the waiting room. And then the intake form. When I'm looking at an intake form, I do a lot of work around sexual orientation and gender identity data collection, because when you think about it, the way that we collect data really shows what we care about. There's the old saying, what gets measured matters. If you're not counted, you don't count. And so when I'm looking at a form for intake, for instance, I'm looking to see, does it have a space for pronouns? Does it have a space for gender, where it's clearly indicated that you might have an F or an M on your driver's license because as a transgender person, you haven't been able to change it yet, but your gender is actually different than what's on that ID document. And does the form give you the opportunity to indicate that? Does it ask about sexual orientation? These demographics matter. These are, key pieces of information that help everybody get the care that they need. And so making sure that you're looking at an inclusive patient registration form, to me, is another really good indication of, oh, this is a practice, this is an institution that has really thought about me, really thought about all the different ways that people are bringing these elements of their personal selves, their identity, to every interaction that they have in the course of their day-to-day life, including going to the doctor.
Would you go farther and suggest the training of the frontline personnel, the receptionist, security people? Training, I mean, as you were speaking, the very simple, no-brainer kind of thing. Ask somebody, are they Mr., Ms., or whatever? How do they want to be called when they're being brought into the examining room?
Yeah, training is absolutely key. There's so much that goes on in healthcare. Modern healthcare is super complicated. It moves really fast, except when it doesn't, sitting in a waiting area or what have you. And so there's a lot of things that front desk staff, providers themselves, other folks in healthcare have to think about. And one of those things that folks need to be trained on so that they have it in their toolkit for dealing with every patient they encounter is knowledge, training about how to work effectively with LGBT people. And that includes some of those welcoming indicators that we were talking about earlier. It also, to your point, includes how you greet someone, not making assumptions on the basis of what someone looks like, whether I should call them sir, call that person ma'am, make assumptions about a person's pronouns. It's really easy to talk to somebody about pronouns. You can just say, for example, hi, my name is Callen. I'll be registering you today. My pronouns are he, him.
Yeah.
And that gives an opportunity for the person. You don't even have to ask them. You can, certainly, if you want to, politely, respectfully, what pronoun would you like me to use? Or what name would you prefer that I use? But you can also just model that behavior by introducing yourself and giving the other person, the person that you're working with, if you're a patient registration staff person, you can just politely model and give the space for the person coming in to talk to you to share that information. So I think training is absolutely key. Knowing, again, how to be welcoming. As a patient, I would be looking for, does the person look me in the eye, really see me, say, hello, it's great to see you. My name is whatever their name is. My pronouns are welcome. And then helps me fill out, the voluminous amount of information that we all have to fill out anytime we visit a healthcare setting.
Yeah. Let's move up a step and talk about the regulations of a hospital. How hospitals change and design their regulations to suit their needs, as opposed to perhaps patient being the primary need.
Yeah, there's a whole raft of different policies that influence the environment in a hospital or another healthcare setting. And really, when we're thinking about policy here, I am sort of generally talking about what we sometimes refer to as small p policy. It doesn't necessarily have to rise to the level of a government policy, like a law or a regulation. It's also about institutional policies. When I teach classes about policy, I often describe it as just the way we get stuff done. It's the way we do things. It's the sort of rules, regulations, guidelines, procedures that help us go from A to B and get the work done and provide the services. So at an institutional level, you are looking at, there's a lot of leeway for hospitals and other healthcare institutions to design the policies that they want to use. For example, some hospitals are very good about training everybody, all the way from front desk staff to janitorial staff, security staff, and then providers about LGBT people and about other aspects of cultural humility and cultural competence, making sure that everyone is prepared to work effectively with every patient. But not every hospital does that. Not every healthcare organization does that. So there's a multitude of ways that institutions make those decisions. Some other sort of institutional policies would be what I was mentioning about intake forms, for instance. Does the intake form include demographics around sexual orientation and gender identity? Does it use inclusive terms for different relationship statuses? Does it provide you an opportunity to indicate your pronouns? Those are institutional policy decisions that are made at the institutional level. And similarly, the electronic health record. Electronic health records kind of are a little bit off the shelf in some, you can go and buy one and then it will have the functionality that it comes with. But a lot of institutions can and do customize their electronic health record to make sure that it has, for example, space for those demographics around sexual orientation and gender identity. So that's another example of an institutional policy that folks can, that you might see an institution employing in order to make people feel welcome. And as we were talking about earlier, to address some of that historical and ongoing mistrust that many folks feel. There's also a number of state and federal policies that do influence healthcare institutions. So, for example, at the state level, a number of states have non-discrimination protections that are inclusive of sexual orientation and gender identity. So that means that people cannot be turned away when they are seeking care on the basis of being LGBTQ, for example. There are also national policies. We just recently had the US Department of Health and Human Services under the Biden-Harris administration release a rule that is part of the Affordable Care Act, which was enacted almost 15 years ago. My gosh, have I been doing this work for more than 15 years? But that rule, it's called Section 1557 of the Affordable Care Act, and it prohibits healthcare organizations, so health insurance carriers and healthcare providers, including hospitals as well as individual providers, from discriminating on the basis of race, color, national origin, age, disability, or sex. And those sex non-discrimination protections are inclusive of sexual orientation and gender identity. So under federal law, no matter what state you're in, no one in a hospital, in a doctor's office, at an insurance company is allowed to mistreat you because you are a person who is lesbian, gay, bisexual, queer, other terms that you might use to describe your sexual orientation, or for people who are transgender, again, people cannot be discriminated against on those bases.
So for a transgender person entering care, surgery, or treatment of some sort, is it reasonable in a medium to large city to expect that they could have a room that matches their identity?
Yeah, and that is actually part of federal law.
Yeah.
So federal law provides for privacy for everybody. So if there is a person who doesn't want to share a room with a transgender person, then that person who doesn't want to share a room, other accommodations can be made for them. But under federal law, hospitals and other healthcare organizations are not allowed to segregate, to isolate transgender patients, or to place them in rooms, on wards, on floors that do not align with their gender. So, a transgender man, for example, who's a person like me who transitioned from female to male, needs to be able to be on a floor, in a ward, sharing a room, depending on my level of comfort, with another man. And similarly, a transgender woman, who's somebody who transitioned from male to female, would then be able, under federal law, to be appropriately housed with other women.
Yeah. And that sort of returns to the intake form in a way. I mean, if you, God forbid, present with cervical cancer, they shouldn't just instantly, mindlessly put you on the female floor.
Mm-hmm.
There's
Yeah.
some, yeah. See,
Yeah.
go on.
Oh, I was just going to say, we're seeing a lot of really interesting efforts by various regulatory bodies to kind of do what they sometimes refer to as degendering cancer. Cancer doesn't care. Cancer doesn't care what your gender is. Cancer doesn't care about anything except its opportunistic, efforts. Except for hurting people. Cancer does not discriminate on the basis of what your gender is, what your gender identity is, whether you're gay or straight. All cancer knows is what body parts you have. And so in cancer prevention, we've long talked about, if you've got the part, you got to get it screened. If you have a prostate, no matter what your gender is, if you're a cisgender man or you're a transgender woman or you're non-binary and you have a prostate, you got to get that screened. And same for transgender men. If you have a cervix or a uterus, regardless of whether you're a cisgender woman or a transgender man or a non-binary person, you need to make sure that you get those body parts screened. And so that's part of this quote unquote degendering of cancer, where a lot of screening bodies, the US Preventive Services Task Force, for example, the National Committee on Quality Assurance, are really looking at their guidelines around cancer screening and saying, it's not about screening women per se for uterine cancer. It's about screening people with a uterus. If you've got a uterus, then you need to be worried about cancer, unfortunately, and you need to get that checked out. So it's not about erasing women. It's not about erasing any particular group of people. It's about welcoming everyone to acknowledge, again, that cancer does not discriminate. And if you have a body part, regardless of how you identify, you got to get that checked out.
Right. And this is more of a scientific question, perhaps, but the idea that some patients in our support group network, which is a national network, and I mean, we served like 102,000 people in
Wow.
2023. A lot of people will say to us, well, I don't really believe I have cancer because, as a gay man, they didn't test that test on, I don't know whether they tested it on gay men, in the same respect that men of African descent, Black men, will be suspicious of any sort of clinical trials saying this medication will work on you, but only 3% of the trial participants were Black.
Yeah.
What do you say to the patient who's skeptical because they didn't test it on people like me?
Mm-hmm. Yeah, there's been a big push over the last couple of years in particular to increase the diversity of clinical trials, recognizing that, it wasn't that long ago when straight, cisgender, white men were taken as the perfect archetype for every human being. There literally had to be a federal law that was introduced, that was passed in the 1990s, in order to require clinical trials and other forms of biomedical research, for example, conducted by NIH, the National Institutes of Health, to include women as well as communities of color. So it isn't that long ago, again, where we had this sort of textbook, incredibly simplistic and offensive idea of what constitutes a human being, and really restricting that again to straight, white, cisgender men. That has been changing. As I mentioned, that law came into effect in the early 90s. So we have seen a lot of efforts at the National Institutes of Health and elsewhere to make sure that clinical trials and other research studies are fully inclusive of the full diversity of the US population. And so one of the things that we're seeing more recently is the expansion of those requirements, not just to federally supported research, but also to industry trials. So a lot of work that's done to bring a medication, for example, or a test to market goes through clinical trials. And we do a lot of those at Whitman Walker Institute. We have been a part of the bringing to market of pretty much every major HIV prevention or treatment medication since the very beginning of the epidemic. So we take clinical trials work really seriously because it's a really important way both to advance the science and improve health for a lot of people, and also because participating in clinical trials is a really important opportunity to get access to breakthrough new options, new scientific breakthroughs as early as possible. So we recently opened a new clinic building in Southeast DC in Ward 8, which is more than 90% African American, is one of the areas of the city that historically has experienced disinvestment. And so there is a real dearth of opportunities for folks in Ward 8 to participate in clinical trials and access those benefits of being able to participate in scientific and medical breakthroughs. So we have been building a biomedical research lab where the entire purpose is to make sure that the studies that we're doing, the folks that we're recruiting and who are participating, are reflective of the communities that we serve and that we're a part of. So that means communities of color. It means folks whose primary language is not English. It means queer and trans and gay and bisexual people, lesbians. It means everybody. So that's a really important element, the sort of advances made over the last couple of decades to require these trials and research studies in general to be more diverse and reflective of broader communities, and also just a real opportunity for individuals to participate. And I think that that's one of the things that I would say to folks who are considering, kind of on the fence about, is this the right thing for me? Was this tested on somebody like me? Clinical trials are very safe. And it's really important for us, as much as we can, as much as we have the ability and the desire, to participate in them, because that's one of the ways that we change the face of science. We saw this in HIV, where gay, bisexual men, other men who have sex with men, transgender women, men of color, participating in clinical trials was one of the things that eventually have brought us to the place where HIV is still an epidemic in so many parts of this country, but where we do have some really, really effective prevention and treatment tools, and eventually, hopefully, cure tools as well.
Yeah. As we wind this down, and it's like to go on for hours, but there are many cancer patients that'll navigate into hospice care and home nursing.
Mhm.
What can you tell us about the institutional aspects of hospice care and home nursing that might both red flag or rainbow flag those services for cancer patients?
That's an excellent question. There's so many elements of the home care industry in particular that are not very closely regulated, which means often that people who are providing that care are really, really, really overworked, really, really underpaid, and not really given a lot of the training that we have been talking about. For example, how do you make sure that you're providing the appropriate care and interacting respectfully with somebody who's gay or somebody who's transgender? So it's a really important thing to make sure to talk to whoever is supposed to be working with you. You should not be made to feel uncomfortable. You should not be made to feel like you have to go back in the closet in order to get the healthcare that you need. This is something that we're seeing, unfortunately, increasing as some of the first generations, to come out around Stonewall or in the post-Stonewall era. Folks are aging now into retirement homes, into hospice care, into home health care. And too often we're seeing reports that people are feeling or being told that they have to go back into the closet. You can't wear that. We're not going to call you by that name. We're not going to respect you for who you are. And that's something that, unfortunately, LGBT people are all too familiar with hearing that kind of thing. So really making sure that you are talking with the folks who are going to be providing care, that you're asking the questions that help you get the information that you need. It's better to ask a question where you're worried, well, what if they don't react well? What if they don't have a good answer? It's better to ask that sooner so that you can make sure to make other arrangements. Much better to find that out earlier rather than to have that, a reality that somebody isn't prepared to work respectfully with you as a gay person or as a lesbian or as a trans person. Better to have that come out earlier before you get into a situation where, you're really relying on somebody and only then finding out potentially the presence of homophobia or transphobia. There are opportunities to complain if you experience that kind of mistreatment or harassment, something like being misgendered or told I'm going to pray the gay away, or being told that your same-sex partner or spouse can't be with you. Those are all illegal under federal law.
Yeah.
And so you can file a complaint with the hospital. Make sure you keep records. It's important to have the documentation of everything that happened so that when there are questions later, because institutions specialize in trying to get out of, try to get out of trouble, but document what happened, send a letter of complaint, follow up. And if you're not getting resolution, then you can appeal to the U.S. Department of Health and Human Services. In many states, you can file a complaint with a state agency as well. And God forbid it ever gets to this, but you can also sue for violations of your right to non-discrimination in accessing care. No one should be able to treat you badly because you are LGBT, because you are a person of color, because you are living with a disability or speak a different language. There are some really robust non-discrimination protections out there. And it's unfortunate that those protections don't enforce themselves. Too often we have to step up in a time of great need and distress. But you didn't miss an opportunity. It wasn't your job to fix that situation. And at the same time, for those, if you do feel a sense of power that comes from being able to invoke those protections, remember that they do exist and take advantage of them.
Right. And many of those protections come from your good work and the work of the Whitman Walker Institute. And we're so proud that you're a champion of the community. And any last thoughts or anything you want to share beyond what we've already discussed?
I just want to thank you for this focus. Cancer is something that has touched my life deeply. I lost my best friend, Andrew Cray, who was also a transgender man and worked with me in Washington, D.C. on a lot of these federal policies. And he was diagnosed with oral cancer when he was 28 and died within the year. And we had such an incredible experience with the care providers. He was at Johns Hopkins Hospital, and we just had such respectful and welcoming care. And this was a decade ago in 2014. And so in many cases, things have gotten even better since then in terms of the openness, the accepting nature, the welcoming environment, more forums that ask, for background about who we are so that they can make sure we get the right care, staff that are trained. But, not everyone is fortunate enough to have access to that kind of welcoming and affirming environment. And that is what all of us deserve, whether we're dealing with cancer or not, but especially for those of us, who are navigating what can be a really scary journey around cancer prevention or cancer treatment. So I'm just really appreciative of your efforts to shine some light on what it is that makes institutions trustworthy and what they can do to make sure that everyone who walks through their doors, whether they're gay, lesbian, bisexual, queer, trans, or some combination thereof, feels comfortable, safe, and welcomed when they are accessing the healthcare they need.
Dr. Callen Baker, thank you so much for your talk today.
Thank you, Darryl.